Good evening and thank you all for joining us today. I, Amit Saxena, along with Dr. Deepika Chabra from Medical Services Department of Jagsonpal, would like to extend a warm welcome to all the SIG to this SIG webinar organized by Indian Fertility Society with academic partner Jagsonpal Pharma Ltd, makers of LycoRed-M, EndoReg, Divagest, our range of natural micronized progesterone. For today's program, convener is Dr. Punita Bhardwaj, Madam. Madam is an expert in endoscopy practicing as unit in charge senior consultant at Sir Gangaram Hospital, New Delhi. The conveners are Dr. Priya Bhave and Dr. Maansi. Dr. Priya Bhave is Secretary, Indian Fertility Society, MP chapter. She is consultant head productive medicine at Bansal Hospital, Bhopal. And Dr. Maansi Jain, SIG endoscopy is consultant in medicine at KJ IVF, New Delhi. Now I request Dr. Punita Bhardwaj, Madam, to please kindly initiate this session.
Thank you, Amit. It's always been a pleasure being here. I've been a convener for the SIG IFS for 2 years, and it's been a delight. Without delay, I request Dr. Kuldeep Jain, who's a founder of Indian Fertility Society and our mentor, to say a few words to begin the webinar.
Thank you, Dr. Punita. And I must congratulate Dr. Punita, Dr. Priya and Maansi for running the SIG so smoothly and bringing out a lot of programs which are really out of box and conveying a lot of take-home messages as far as the scientific content is concerned. So this is another webinar on tubal surgery versus IVF, and this has been always in debate. But when we speak of tubal surgery in today's era, it has always been the surgery versus IVF has always been in debate. But in today's practice, we always take advantage of the both of the modalities, and whenever the patient comes with tubal factor, one has to take the lot of things in consideration before deciding whether the patient has to go for tubal surgery or for IVF. There are over the period we know that there are limitations of tubal surgery, and you have to be really selective when you are providing the surgical management of tubal factor. Otherwise, IVF is always there as a ultimate modality for all tubal factor who are not conceiving even in spite of a good surgical correction. So without delaying much, I think Priya is going to speak on the subject, and I am sure that this will be a delight to hear her. Priya, all is yours. Thank you very much again, and I wish the webinar a huge success, and I am sure that a lot of take-home messages will be there for attendees. Thank you.
Thank you so much, sir, for the encouraging words. It's always a pleasure to interact with Dr. Kuldeep Jain. And needless to say that his contribution in the field of IFS is beyond these small slides. Thank you so much, sir.
Thank you, Dr. Punita, for kind words. Thanks.
I now invite the President of Indian Fertility Society, Dr. K.D. Nayar. He's, he's been the president and an active member, and he's a great person who encourages everyone. He's very amicable and encourages you through and through, and a very positive person. And his special interests are on poor responders. He has had a lot of international and national presentations, and in ASRM and ESHRE meetings since 2017. And he's had the privilege of having a star award, ASRM 2020, ASRM 21 and 22. So that's a hat trick. Dr. Nayar,
Anyway, good evening, ladies and gentlemen. It is my privilege to welcome all the delegates to this CMB, the webinar being organized by SIG Endoscopy. I bring you greetings from the entire IFS family of more than 4,200 members, spread over 29 chapters. And at the outset, I would like to acknowledge the efforts of Dr. Punita Bhardwaj, the convener, Dr. Priya Bhave, and Dr. Maansi Jain as the co-convener of this SIG, who have successfully organized many webinars all over India. I also acknowledge the efforts of all the speakers, chairperson, and moderator who are going to make the webinar an academic benchmark. It makes me proud to see how the SIG in IFS has grown in the quality of academics. We have 18 SIG in IFS, and you can become member of any SIG for an in-depth interaction with a stalwart in the field. During our tenure, we had planned for pan-India data collection, and we have already finished with 6 surveys on different topics. We are analyzing the data, and we are soon going to publish result of the first survey next week. And we're going to publish all the results of the 6 surveys. We have also released the draft of Indian guidelines on poor ovarian response, which has been released on IFS website for a national and international stakeholder review. The review is open till 25th March. Any of you can give a review, give a comment. We'll take into account before finalizing and publishing the guidelines. We are also formulating a consensus statement on psychological support for medical assisted reproduction, and we hope to release it in the last week of March. The term of present executive in the center and state chapter is to end on 31st March, and we are in the process to elect the new executive for the next term. Finally, I am again congratulating Dr. Punita Bhardwaj and the whole team for organizing this webinar and wishing them an exciting future ahead. Thank you.
Thank you so much, sir. It means the world to us for your kind words and amazing achievements, sir, that you've enumerated. So many surveys and so many manifestos reaching to the guidelines. Wonderful, sir. Thank you so much again to spare your time and be with us. We now welcome Dr. Priya Bhave Chittawar. Her claim to fame is not only being a consultant and head Department of Reproductive Medicine, Bansal Hospital, Bhopal. She's a FNB teacher. She's ex-faculty reproductive medicine and Foxy recognized trainer in basic and advanced infertility management courses. She's also a Cochrane reviewer and author. Apart from that, she's an Iron Man, our very own Indian Iron Man. That's quite something, you know. So we congratulate Dr. Priya Bhave on her achievements and invite her for a talk on tubal surgery versus IVF. Dr. Priya Bhave.
A very good evening to all of you. I am really pleased to be a part of this very important webinar today, mainly because it is probably the final webinar of our SIG. We had a very great time working with Madam and under the blessings of Dr. Kuldeep Jain sir, who has been such a wonderful mentor. And we will really miss working under Dr. K.D. Nayar sir and Dr. Surveen, who have been really so cooperative, so encouraging that it fills us with a lot of enthusiasm. So when we talk about tubal surgeries, we all know that IVF basically was invented as a treatment for tubal factor infertility. Prior to the IVF, the tubal surgeries were the norm, and there was a lot of work which was done in tubal surgeries. Of course, in that era, they were performed as open surgeries. Now, ever since this first IVF, the indications of IVF have really expanded. So now we are doing IVF for many, many more indications, more than tubal surgery. As I said, the access to IVF has improved. The success rate has improved. The training has improved. So somewhere, the tubal surgeries have taken a backseat. Probably in today's day and age, the only tubal surgery that an ART specialist does, paradoxically, is delinking of the tubes and salpingectomies. I mean, I know very few IVF consultants who also do tubal reparative procedures. Of course, so when do we actually need to do them? When there is an infectious tubal block or there is a post-tubal ligation tubal block. Now, in our country, tubal blocks are mainly because of chlamydia or tuberculosis, but as we see in our practice, most of these blocks are either because of post-procedure, say post-abortal infections, postpartum infections, or they are because of tuberculosis. We do see cases because of chlamydia once in a while. And if we look at the site of these blocks due to these infections, most of the times cornual blocks, they could be some mid-tubal blocks, but that is rare. And distal blocks, again, because of both chlamydia and tuberculosis, leading to a hydrosalpinx. Now, the corrective surgeries that can be performed in infectious cases, that is post-infectious cases, could be a cornual cannulation, a salpingostomy, or a neosalpingostomy. But we have to remember that tube is not just a passage, it's an active organ, and tubal patency does not equate to a pregnancy. Most of the times, what happens is when we open a tube, if there is a significant mucosal damage, if there is significant damage to the cilia of the fallopian tubes, this tube is not likely to function properly. So somewhere over the last 20-25 years, the cases who will do well with these procedures have reduced very drastically. In our own series, we have a very big series of post-tubercular tubal block. And we find that these infections usually cause multifocal tubal block, proximal, mid-tubal, as well as distal, and most of these are not amenable to repair. So this is the spectrum what we see in post-tubercular blocks. And unfortunately, except for some cases where there is this isolated cornual block, very early tuberculosis, post-tubercular blocks are not amenable to repair. And in fact, tuberculosis is actually a contraindication to a tubal reparative surgery. So what kind of damage do you expect to see? You can see a hydrosalpinx, tubo-ovarian adhesions, beaded tubes, edematous tubes. Many times we see these tubes thinning and a diverticula forming. So as you are injecting the dye, the tube fills up like a balloon and you feel as if it is just about to rupture. Sometimes fimbrial end agglutination. Towards the end, as fibrosis sets in, we have a rigid tube and an extravasation of the dye in the wall of the tube. This is very, very characteristic of post-tubercular infections. So my take-home message is that in these infections, surgery is not going to help. Very early stages, isolated cornual block, it might. But whenever the entire tube is involved, there is absolutely no role, except probably in some cases for a hydrosalpinx removal. The cases where we are actually realistically looking at a tubal reconstructive surgery are those patients who have had a tubal ligation surgery. Now, tubal ligation, at least in MP, it will be surprising that the results of National Family Health Survey for the last decade are out. And what they said is, even in the rural areas today in central India, the number one technique of which the patients like to use for contraception is a tubal ligation. And that is why in our practice, we do see a lot of patients wherein either they've married again or there has been an unfortunate incident with the child. And because of this, the couple now needs to undergo a recanalization procedure. Now, most of the times, what we need to look into is how was this tubal ligation done? So many times in our country, most of the times it is the Pomeroy's method or the modified Pomeroy's method, wherein a segment of the tube is removed either through a mini laparotomy or a postpartum surgery. Sometimes but we do see that they have removed the fimbria or a fimbriectomy has done. These are surprises, but we do see them. So the factors that are very important for us to know is if it was a laparoscopic tubal ligation, this has probably got the highest chance of a good recanalization and good success. The time since she had a recanalization, so if she's had a tubectomy 10 years ago, then there's likely to be a lot of fibrosis, and this patient may not do very well with the recanalization surgery. How much was the size of the loop? Sometimes even in a laparoscopic tubal ligation, we find that the loop is either placed very, very proximally, so you don't get a good proximal stump. Sometimes it is very distal, so you get a lot of luminal disparity. Also, the residual tubal length, what is the length of the remaining tube? Conventionally, we were told 4 centimeter, but in my experience, the longer the tube, the better is the chances. In fact, 4 centimeter is the absolute lower limit of what the tubal length should be. Never forget to look at the fimbria. Many times it happens that during a laparoscopic tubal ligation, the doctor finds that the patient has PID or hydrosalpinx. They still go in and do a ligation anyways, because this couple gets some benefits if they have a tubal ligation surgery, even though she has endometriosis or tubal issues. So just the fact that she has a tubal ligation does not mean that we don't look at the health of the rest of the tube. Also very important to remember is that many times these are fertile couples, but sometimes with aging, with some addictions, there could be a male factor infertility also. So the basics are very important. Always get a good semen analysis, check the ovarian reserve, and also look at the cavity. So look at the couple as a whole and not just as a tube which needs to be joined again. Now, this is a very common situation that happens in our OPD. Till 10-15 years ago, the patients would always come in saying that I want a recanalization. Now what happens is they come in and they ask us कि हमको directly IVF करना है. This is because now the awareness for IVF has increased and now patients know that it has got a good success rate. But advantages of IVF are definitely there. This patient does not need to undergo a big surgery. There's a very good success rate. So if the lady is a young lady with a good ovarian reserve, we get almost 40 to 50% pregnancy rate per cycle. So with 2 embryo transfer cycles, there's almost a 70 to 80% chance that this girl will have a pregnancy. But the disadvantage is that these couples usually are in a desperate situation. Either one of the children has died or she has gotten married again. And so there is a rush to conceive. But we have to remember that IVF will give them 1 or 2 chances depending on how many embryos are formed. Plus in IVF, inevitably, in India at least, we end up transferring 1 or 2 embryos. In case we transfer 2 embryos, then there is a likelihood of a multiple pregnancy, which actually is an undesirable outcome in IVF. We want the birth of a single successful singleton at term, and multiple pregnancy has risk not only to the fetus but to the mother as well. So actually, it's a disadvantage of IVF. And of course, compared to a recanalization surgery, IVF is costly. The advantage of doing a good recanalization is that this patient can try multiple times. So you've done a surgery, they can try 6 months, 7 months. They can even try and conceive again if they have had one baby. So it gives you multiple cycles. When it is done properly, when you have the skill, when you have the technology, and your patient is well counseled, you also get a very good success rate. The disadvantages are definitely it's a reparative surgery, it's a microsurgery. So doing it not only laparoscopically, but even by laparotomy requires a different kind of skill set. That is why we see that there are certain doctors who specialize in this procedure because they do this procedure more often than all of us, and their success rates are definitely higher. But we have to remember that there is a ectopic risk. Whenever we rejoin the tube, there could be some tubal constriction and there is a chance of ectopic pregnancy. In fact, in my own series, I've had 3 ectopic pregnancies in patients whom I have done a successful recanalization. Definitely, there's no chance of a multiple pregnancy and the cost is higher. Now, this is about recanalization, but I must mention a word here about 2 other surgeries for distal tubal block. One is a fimbrioplasty. Now, fimbrioplasty is done when you see a distal tubal block because of infection. You put an incision on the opposite end of the mesosalpinx and you just evert the flaps. Practically, you are also supposed to suture it, but most of the times it is left as such everted. Now, in this procedure, there is a very low success rate. If there is an infection, then there is likely to be an impairment of the tubal motility as well. So this procedure is done very rarely. Similarly, salpingostomy, where you make a cruciate incision, where you evert out all the fimbria and you also suture the fimbria back. Now, in my experience, this procedure can give you a patency, especially very successful in patients with chlamydial hydrosalpinges. But in my own series, the pregnancy rate is very dismal. So practically now, I have stopped doing this procedure of salpingostomy laparoscopically. Now, how to counsel a patient who is here for a tubal surgery? The first thing that we tell them is that whenever the doctor was doing your tubal ligation, he or she wanted to ensure that you never conceive. And that is why, although the size of the loop has to be 1 centimeter, it has to be a mid-tubal procedure, many times we find that the loop has been very, very proximal, or the loop is very distal, or the fimbria are destroyed. So we always tell them that we'll do a diagnostic, and then if the tubes are recanalizable, only then we are going to proceed. Similarly, after this procedure, there is a risk of ectopic pregnancy. So we explain to them that anytime you have a delayed period, or she has a scanty period, or there is unexplained abdominal pain, she immediately has to report. If her UPT is positive, they should first get an ultrasound to make sure it's an intrauterine pregnancy and not an ectopic. Another thing that we tell them very clearly is we can try and restore the patency, but tubal function is a different game altogether. Although in patients with tubal ligation surgeries, tubal function is likely to be normal, but we are not able to restore that or ensure that it gets restored. And of course, we have to tell them is that in case you don't conceive in a specific time frame, which is individual for each patient, we are going to take you up for an IVF procedure. Or if we find that the tubes are not recanalizable, we are still going to take you for a recanalization procedure. Now, what are the tips that I would like to give and what I have learned from the experts? I always use vasopressin in the mesosalpinx. This gives me a very good hemostasis. It doesn't involve cauterizing of any of the blood vessels, and so it gives you a very good vascular reanastomosis. Secondly, always excise the scar tissue. Luckily, laparoscopy gives you that tactile sensation. So you can actually feel and you can see a whitish scar tissue. So be ruthless in excising that. Always confirm a proximal patency. So after I've cut, my assistant will inject the dye. I'll make sure that it's coming out from the proximal end, and only then I will proceed. Ensure that there is a luminal parity. What do you mean by luminal parity? Both proximal and distal lumina should be of a equal or equivalent caliber. Now, sometimes the proximal end is smaller and the distal is bigger. So what we do in these cases is a fish mouthing. So I give a vertical cut, and so that the smaller proximal end becomes bigger and there is a more luminal parity. Always ensure there is a distal healthy fimbria. Conventionally, 4 sutures were taught in the mucosa and 4 in the seromuscular layer. What we have done is we don't take a suture at 12 o'clock. We take a suture at 12 o'clock, 4 o'clock and 7 o'clock in the mucosa. And intermittently, we put 3 seromuscular sutures. So my technique is to use 3 sutures in the lumen and 3 in the seromuscular. We use a proline 60 for the luminal reanastomosis, and we sometimes use it the same proline for the approximation of the mesosalpinx as well. So this is a video showing the procedure. In this patient, it was a laparoscopic tubal recanalization done. Here, the loop was placed very, very proximally. So you can see practically there's only a ring and there is no tubal stump, or there's a very, very small tubal stump proximally. So whenever we get a chance, we must always tell the laparoscopic tubal ligation surgeons that try and leave at least 1 centimeter or 0.5 to 0.7 centimeters from the proximal end, and don't go too much distally. What I use are normal 5 mm instruments. I have experimented with using smaller instruments, that is the pediatric needle holders, but I find that we are more comfortable with this. So here I am reapproximating the mesosalpinx. Luckily in this patient, the luminal parity is good. So both the lumens are almost similar. So the first suture, I always take it around 7 to 8 o'clock. So you go outside in and then you go inside out. So here, this is the second suture, which is the 12 o'clock suture. I'm going from outside in and then I'm going to come inside out. So this is the luminal suture being tied. I always tie the upper suture first, and then the lower suture, which has been left as such, is tied later on. This is the suture at 10 o'clock position. So these are basically the luminal sutures that we are using. Now you can see what we have done is there is a sleeve of the serosa which has been dissected back. So this gives me an additional layer. So now when I'm reapproximating the serosa, this nicely covers the mucosal anastomosis. and it gives a very nice final picture. And it also kind of is a buttress. So the mucosal stitches, they hold up well because we have kind of buttressed it with the seromuscular layer. Now, this is almost the final stitch of the anastomosis. In some cases, what happens is it's more distal. So this is a case which we've done yesterday. And here you can see that the tubes are quite distal. So there's a very long proximal end. Now the problem here is going to be that as I'm injecting vasopressin, you can see practically the distal end is very, very big. And you can almost see the mucosal folds of the tubes here. And this is the, so this lumen is almost double that of the proximal lumen. So what I'll do is I'll do a fish mouthing. I'll cut the lumen. Again, I'll go down, take the first suture. First take the mesosalpingeal suture. This is the 7 o'clock suture that I take. So it goes outside in, inside out. And finally, the upper two sutures. Finally, we will use these serosal sutures. This is my favorite step because it gives you a very, very neat anastomosis. It acts as a buttress for your mucosal sutures. And it actually kind of gives you an additional layer. So when you're injecting the dye, it doesn't come out, and it gives, probably I feel that the mucosal healing happens better because of these seromuscular sutures that we use. So this is the final picture. Now again, on the other side, there is a lot of fibrosis you can see on both the sides. So this side also we did the same thing. The lower suture outside in, inside out. Then the upper sutures. How to give the post-op care to these patients. Now, the last step which I have not shown here is the injection of the methylene blue. Earlier, I was a very big advocate. It makes everybody very happy. When you operate in a workshop and the dye comes out, you get a standing ovation. But sometimes I feel that we are using 6-0 or 7-0 proline. When we are injecting a dye under pressure, I always feel that there actually may be a little pressure on the anastomosis. And because of this new visual systems, we are actually very sure that we are anastomosing the lumina. We are actually able to see the endosalpinx. We use a Rubina system with a very big monitor. So practically, I feel that injection of methylene blue just to demonstrate the patency, it is actually not required if you have confirmed the proximal patency before the anastomosis. You still can do it, but I feel that because of the stress of injecting that methylene blue, you actually put additional sutures on the seromuscular layer. So in some cases, we don't even do it. Post-op care, it's important for them to avoid pregnancy for 1 month. Then we give them fertile period of 3 to 9 months, depending on their clinical profile, and we tell them about ectopic precautions. So to summarize, a good selection of the cases. Don't take cases who already have infection, who have multifocal blocks, who have destroyed fimbria, who have low AMH, who have spent a long time after their tubectomy surgery. Use a very good technique. So this requires a lot of skill in endosuturing. It requires a very good laparoscopic system. With a normal 3-chip camera or with a normal single chip camera, we should not even be attempting these procedures. And a very important thing is good peroperative counseling. That is because these couples always come with a sense of urgency. They've either lost a child or there has been a change in the marital situation. So they are very, very desperate to conceive. But we should never forget to look only at, never look only at the tubes, but we should look at the couple as a whole. And there is definitely a very important place of tubal recanalization surgery, because while IVF has advanced, so has laparoscopy. Just as the skills of IVF doctors, embryologists, culture media have improved, so has the skill in endosuturing, so has the cameras and the endovision systems. So I think time has now come where we actually think of recanalization very, very seriously in a certain subset of patients. So thank you so much for a very patient hearing. And thank you, Punita ma'am, for considering me for this topic. It is something which is very close to my heart because I do a lot of laparoscopic surgeries along with IVF, of course. So I would love to have any discussion and your insights because you have a vast experience working in one of the best hospitals of the country.
Well, that was great, Priya. Thank you so much for elaborating on both the aspects, and you did balance it out in the end. although I think your core says IVF, but but I think it's important in this era. You can't brush away recanalization surgeries. And it's important to understand both the aspects. If you are an IVF person, all right, go ahead and do an IVF. But like you said, case selection is so important. And the crux is case selection. I think what you emphasized again and again, and of course, the pre-op counseling. Another thing I wanted to know was that whether you do unilateral recanalizations or bilateral. There are a lot of people who go in and just do one side. And I feel that doing bilateral gives a better chance to the patient rather than just doing unilateral. Like you said, you have the internal disease patterns, which you don't know. You're not just receiving patency is not the idea. The idea is to get them to bear an intrauterine pregnancy. So what do you have to say about that?
Ma'am, I would always do a bilateral. I never do unilateral because, of course, if the patient has paid for the surgery, she deserves the best chance. Many times it happens that I do recanalization for one tube. The other tube is not very much recanalizable, luminal disparity or whatever. But as far as possible, I try and do both. Because see,
Yeah, so
earlier,
it makes sense. Makes
yes,
sense that you're going in, you are making that effort. It's costing the patient that you give her a best chance, which is possible in her case, rather than do one side. And I like the idea that you emphasize that the distal end is important. You can't just achieve the recanalized portion patency and leave the rest of the tube to chance. So it's important. And initially, I think when we were younger, in our PG days, we were taught do an HSG before recanalization. So now, do you do that, or you've given away with that practice of doing a proximal tubal patency as an HSG, or do it per op when you're doing the operation?
don't do an HSG because HSG probably used to be done to know the length of the proximal stump. But we are doing a laparoscopy anyways, and we are going to inject a dye and make sure that the proximal end is patent. Only then we'll go ahead.
Right. And what would you do? There are a lot of studies talking about a single stitch. What do you think about that? A lot of people are using only 2-stitch, just approximate, and that people say that it's more than enough to achieve patency and hence eventual functionality.
I'm actually quite intrigued by that. So earlier I used to struggle with 4 stitches because with 4 stitches, I always had a little difficulty. Our operative times were longer. Ever since I've shifted to 3 sutures, so 4 o'clock, 7 o'clock, and 12 o'clock, things are easier. But I have not yet dared to go and do only a single stitch. In fact, I am actually very fond of the seromuscular stitches because I feel that, at the end, it should look also good. So I
Yeah.
don't do a single stitch.
Yeah, so no, there are literature studies where they say 2 stitches. The most important stitch is the 6 o'clock position, and a lot of people are doing through and through the mucosa, single layer. They
Right.
go through then they've gone ahead and talked about
Barbs.
using V-lock sutures for recanalization. I wonder how it works, because it constricts the tube at that end. So probably I wouldn't agree that far to be using V-lock, because as you tighten the stitch, you kind of kink that area of the tube. If you're taking a
Also,
continuous around.
here we are actually not looking at continuous sutures. So I think V-lock actually doesn't make much sense. See, anybody who has that level of skill who is attempting a recanalization will be able to put a knot.
Exactly my point. So I think V-lock should be taken with a pinch of salt.
Right.
And single stitch, of course, is a no-go for not everyone, not for every case. And it's important to have the approximation of the mucosa. The rest, like you said, should look good also. How long do you think the patient should be waiting post-surgery to start her conception?
I've made this mistake. So earlier, way back, I used to ask the patients to try right away. But 2 of them ended up in an ectopic. So I always give them 1 month. I don't give them very long. There are
Right,
some doctors who tell them not to conceive for 3 months. Currently, we are giving them 1 month.
right.
My logic is
Yeah,
that mucosal healing should not take so long, and the
so
best
long.
chances are immediately after the patency has been achieved. So we
Right.
tell them to avoid pregnancy for 1 menstrual cycle after the surgery.
Okay. And what would you recommend? A lot of people talk about the distal tubal cilioscopy, so to say, A lot of people talk about the distal cilioscope, and everybody doesn't have that kind of instrument. It's a very delicate instrument, and to be having that adds on to the costs of the patient. So do you think a distal cilioscopy or a look into the distal end through a microhysteroscope is a feasible option to know exactly the tubal situation and to be able to predict the conception levels later on?
I think in patients who have hydrosalpinx and we are contemplating whether to do a salpingostomy or to do a salpingectomy.
Yeah.
Probably theoretically to see the mucosal folds, it may help us, because doing a salpingectomy for a patient of infertility, it's a very big decision. Personally, I have never done it. I'm actually quite keen to see if I'm able to with the hysteroscope or with the instruments. But I think for a post-tubal ligation patient where you are able to see that the serosal part of the fimbria is normal, I don't think it's required for post-tubal ligation patients. For post-infectious patients, probably could
Yeah,
be a
so you
no.
would recommend it in hydrosalpinges where you want to save the tube, or where the patient is too keen to have the tube and not do a salpingectomy. Of course, that holds for mild. The major hydrosalpinges, of course, you straight away say that you go for IVF, and probably you clip the proximal end or remove the tubes. Isn't that so? Yeah. And I have found that some very few cases where we need to do a fimbrioplasty. And like you were saying, to keep the fimbria everted, do a stitch. What we used to do is a very delicate cautery on the the outer layer of the tubes, to keep the fimbria everted. A lot of people don't want to handle the tube with the sutures, because it's a delicate area, and everybody might not be very conversant with that kind of suturing. But if you
Also,
just
you need to
cauterize,
move. Right.
it's a very delicate handling, fimbria. They start bleeding the moment you touch and tug at them. So you don't want any fibrosis or any damage to the fimbria, whatever is left of it. And so if you can also evert the tube by gently touching with the cautery superficial layer, it keeps everted, and the effort is minuscule compared to the suturing that you mentioned. Of course, if you are adept at it, nothing like it. So tell me one thing, what are the costs of IVF in your center or wherever you're off doing your IVF? What would be the running cost? Approximate, nothing specific.
It's 65,000 for the lab charges. The medicines are as per actual, so it should come to around 1.5 to 2 lakhs. Of course, there's a lot of variation between centers, depends on the type of drug used, but I think 1.5 to 2 lakhs can be a reasonable ballpark figure for at least 60-70% of the centers of our country.
Right. And what is the incidence of conception? I mean, the success rates of IVF that you have by and large in most labs.
So at present, our last year's pregnancy rate for a frozen embryo transfer, because that has almost become the norm now, were almost close to 62%.
Oh, wow.
The cumulative pregnancy rates are higher because if the patient gets more than one cycle, so practically after 3 good embryo transfers, 90% of the patients are expected to conceive. The
That's
only
wonderful.
problem,
Yeah.
10% still will not.
Right.
So for a patient who is fertile, who's had a tubal ligation and now
This
wants
is
to
what you're talking about, the take-home baby rates also, or is
So
it
this is
pregnancy rates?
So the patients who see a sac on ultrasound.
Oh, okay. And your take-home baby rates would be?
It would be maybe somewhere 10 to 20% we can reduce, because that's the miscarriage rate. Of course, depends on the age. So
Right.
we can say anywhere between 40 to 50%. Now that's a very big improvement over, say, 10 years ago, where it used to be between
Yeah,
20
10 to
25%.
20%. And
But I
and
think
then the costs were also, I think the cost of IVF have also come down with the demand and the
absolutely.
know-how. So I think recanalization and IVF, the extremities of costs have reduced with the time. So people, because tubal surgery or tubal recanalization was offered to people who can't afford an IVF. Also, that was one of the factors, the cost. So I guess if your success rates are so good, and what are your recanalization success rates?
So the thing is that recanalization procedures over the last 3 years, we have done not more than 10 cases.
Okay. So that has gone down over the years. I have also seen in my center,
Gone
the
down,
recanalization
plus,
rates have declined with the IVF coming up so well. So I guess people are opting more for IVF rather than recanalizations, or probably the tubal, this thing, post-ligation cases are reducing.
also.
Good evening, Dr. Sudha.
Hello, good evening.
Madam, we would like you to pitch in with your experience of IVF vis-a-vis tubal recanalization surgeries.
I know the tubal recanalization, when I was in Maansi and IVF was not available. So in that case, we used to do many, even the tuboplasty, which is called, where the iatrogenic, idiopathic reason for the tubal PID, we used to do. And even I've done the fimbrioplasty and the ostomy also. So that was quite difficult. But after IVF, people started taking that the IVF is easier. Why to open up? Why to do? If you do by the endoscopy, the success rate was not that great somehow in our center, in a Maansi, in a government sector rather. So this was very, very difficult. So in these circumstances, we have done tubal recanalization of reversal surgery, and that if the age it is less than 35, then the chances were very bright, no doubt about it. Within 6 months, patient used to conceive.
Right.
But when it is the later age, like 40s, then it becomes very, very difficult in those chances. That was the difficult task.
Dr. Priya?
Yes, ma'am.
Can you sum it up, please?
I think how I look at it is, as things improve in endovision systems, as skill improves. So I see that 2 or 3 centers might emerge as center of excellence for recanalization. And probably that is how it should be, because it's a skill. Not every laparoscopic surgeon has this skill. Some of us are better at it. And also the numbers which we do. So what I see is that realistically 2 or 3 or 4 centers should have the expertise for this. I think as time goes by, as the uptake of tubectomy or tubal ligation is reducing, this will reduce. But I think it's a very beautiful surgery, and when you get the result, you feel really happy. So I think this is an option which all of us should give to our patients who come with this situation.
Absolutely. And considering the costs and everything put together, depending on the kind of client you have, you could offer both this thing with good chances. Thank you so much, Dr. Priya. It was an amazing experience having you with us. And you've been a fantastic co-convener with me. All the best in your future endeavors. Thank you very much.
Thank you, ma'am. It was such a pleasure to work with you, and we look forward to working more with you in the future as well.
Most definitely. Thank you. It's always been a pleasure interacting with Professor Sudha Prasad. She's always a delight, very encouraging, very forward-thinking. We have amongst us the director of Maitritwa Advanced IVF and Training Center, New Delhi now. She has a teaching experience of more than 38 years, sorry. She's been a past president of Indian Fertility Society, 2022. She's been a past vice president of OXY, 2019. Past president of AOGD, 2016 and 17. She's been a former professor and IVF coordinator, IVF and Reproductive Biology Center at Maulana Azad Medical College, New Delhi. The fellowship in IVF and Reconstructive Tubal Surgery, Baylor University, Texas, USA in 1993. Do you imagine that?
It is enough, Punita, it is enough.
No, ma'am, I have to tell this to everyone. Started the first low-cost IVF at public sector institution, that is Maansi. She's been a former dean faculty of medical sciences, Delhi University. And of course, it is endless. Her achievements are endless. And she was the first person to start an IVF center at Maansi. It's an amazing privilege to have her with us. Dr. Sudha Prasad, as an conversation expert with us this evening.
Thank
Good
you.
evening,
Thank
madam.
you so much. Thank you.
Madam, I would like you to start right from the very beginning. Where did you do your MBBS from? Where did you do your post-graduation from? And how did you reach Maansi?
Okay. So I did my MBBS from Ranchi, which used
Okay.
to be called as a Rajendra Medical College. Now it is called as a RIMS,
Okay.
because my parents were there and that was the closest medical college from my house. So
Okay.
we never thought to go anywhere. I started there. When I finished my MBBS, then I got the post-graduation in All India Institute of Medical Sciences, Delhi.
Wonderful.
And I did my MD from there. I did my senior residency from there under Dr. Hingorani. She was my mentor. She was my, you can say, guardian. And I really loved her, the way she used to, and I think little bit, very small limit, I have adopted her nature also somehow.
Yes.
It happens. I think
It happens. Yeah.
Yes. And in 1987, just after finishing my senior residency, I joined as an assistant professor in Maulana Azad in 1987.
Okay.
So in 87, when I joined, we were not used to of a private sector of peripheral medical college, even though it was in Delhi, but there was lots of difference between Delhi medical college and in the All India Institute. So
Okay.
I tried my best to put the same kind of academic, same kind of discipline. It was too difficult. And Dr. Hingorani used to run the infertility clinic. So I have seen the passion in her, and same way, the passion I also adopted. When I went to Maansi, then I thought that I will start the IVF center there, or an infertility clinic. There was for a namesake, the infertility clinic was there, but not in a normal usual form.
Right.
So I asked that I want to start IUI. So people said, IUI, we can do from outside. There is no place, nothing. And in Maansi, there was a small room of called to be a hemoglobin lab, where the one person used to sit. I asked, is there any centrifuge machine? How to get it? Then somebody has shown me there underneath a shelf with this much of mud. And 20, 30 years since then, it was there inside. I said, my God, let me take out. I took out, cleaned by my own hands, and I found that it is a Remy of old version.
Okay.
So the Remy machine was there. And fortunately, the Remy is the head office is in the Daryaganj only, opposite the road of Maansi.
Okay.
I said, I don't have money. You just come and see and correct it. The poor person came and said, okay, ma'am, in future, I think you will buy the Remy. So I'm just making it correct. And the way I started IUI in Maansi. But
what got you into IVF? Was it the IVF clinic run by Dr. Hingorani which pushed you into
that
the...
time, in 87, in 85 to 87, there was no IVF clinic.
Yeah.
In 2006, I started and the M started. Neck to neck, we started.
Okay.
So, but it is a very, very difficult, tough journey to start a IVF center in a public sector. I will tell you, Punita, it is very difficult.
Yes, we want to know everything. We want to know everything.
That's what I want to tell you, that if your HOD does not want that you should start the super specialization and your name will come in that Dr. Sudha Prasad has started IVF, so they won't like. Nobody will like it. I must tell you this very clearly today. And
that was such a lovely mentor in Dr. Hingorani.
And after that, you can see Maansi, how much struggle I had to start the IVF center. Right. And it was a passion here that I have to, when I used to refer to Gangaram, or Bombay, or Bombay, So it was so difficult. Patient never used to go. They used to say, no, ma'am, we will be here only. You look after us. I didn't have any facility. Nobody wanted to go. I said, why? Am I capable to do IVF or not? I went to see many centers in Delhi who in a private sector, and I said, it is nothing. And after in 93, I saw the Baylor University where the best IVF center was there. So I used to compare the Baylor University IVF and Delhi IVF. So they used to make in a small place. You must be knowing the Gangaram Hospital had a small room of IVF and embryo transfer room. I saw that. Then I got a comment also from some private sector. Yeah, you people in a government, you should do hysterectomy, you do sterilization, you do delivery. IVF is not meant for you people.
Oh, is it?
So,
I don't believe this.
Yes.
Did the private people say this?
Directly on my face. So it came here again. No, now so
I think it touched your heart. I think it touched your heart.
Yes. I said, I can't stop now. I have to make it. But it is very difficult if your senior officials do not know, do not understand, and don't want to give you that benefit that, okay, this is a super specialization which is going to start at Maansi. So our name will also come. IVF center is in the Maansi now in a public sector. Very difficult task. It took I started in 2006 and I started in, say about 97. So nearly these many years, 8, 9, 10 years, wow. People thought I have become mad because my file was so thick. People used to tell me, just throw this file and go to private sector, you will do best. I said, no, I have to start here only now.
It has the private sector has already said that don't do it.
Yes. Yeah. So it has really pinched me that I will start here only.
So how did you get around these people to think your way?
So I went to ministry. I wanted to take the fund from Home Ministry. I wanted to take the fund from the Central Health Ministry. Nobody was feeling that, no, IVF center in a government sector, population is so much. We have to do sterilization. And then why you want to increase the load of the population unnecessary by making? Then I got many secretariat people to clinic, IVF infertility clinic. I said, you sit for 15 minutes here and see how big stigma is this. Yeah. So I have really tried to touch their emotion that yes, this is the problem. Where if the patient has no child, what society says to them and how the whole family is behind, even though the husband is azoospermic,
Yes, that's the irony of the situation.
Yes, the culprit is the female only. That is
always.
That is the big problem.
Even today, madam, even today, the thought is the same. My son can never go wrong. It must be the lady which is at fault.
Only lady is wrong. That is true. Yes. Very true.
Yeah.
So that is the problem at hand. And it was so difficult. With a great difficulty, somehow, there was a dental hall, dental clinic. So that dental medical college was made at the back of the Maansi, the Maulana Azad Dental. And then I got that place. I said, no, this place I really need. I was behind and it was so difficult to take it. I went to secretary. Secretary has sanctioned. Because if you start from below, from your department, it is very difficult. I am saying very, very clearly to you. Right. So the secretary has given me that dental space to be given to Sudha Prasad.
Oh, the dental people didn't fight with you?
No, dental was shifted out.
Okay.
Dental shifted out to dental college.
They were given alternative place.
Alternative, big multi-story building came. And then finally that hall of nearly 2,500 square feet hall was there, and I got it.
Wonderful.
And you can't imagine, I used to stand there. I have drawn that drawing that this is the space where will be the IVF lab, where will be the OT, where will be the patient sitting area. I draw on a paper and I have given to the PWD.
Okay.
This much I did.
Yeah. So you learned all this at Baylor, Texas?
Texas.
Okay, fine.
So it was so difficult for me to make, but secretary that time, Dr. S.P. Agrawal, was very good. When I have given the proposal to him, he said, Madam, आप एक बैलगाड़ी मांग रही हैं और एक हवाई जहाज मांग रही हैं. मैंने, what do you mean? Means everything is required, because there was a long list of, there was a small thing also, and there was a big incubator or ICSI machine was also there.
Right.
So see the difference. Why you are making so many things together? I said, without something, small thing, the IVF cannot be run.
Right.
So he was very kind enough. He has sanctioned the money on my name. The letter came on my name, and you can see my HOD. She took the letter. She went to purchase section and she was jumping that how this letter came on her name, because
Wow.
this should come on, this should come against my name, that I have started the IVF center. It was a terrible time, Punita, but
Yeah, I can imagine.
Passion was there. So I said, I have to start this. And 9 to 4 is the timing of government hospitals, you know.
Yeah.
I used to sit up to 7:30, 8 o'clock to make that. Even my children were small. They used to say, Mama, if you will make your own house, you won't go to see in a mud, you know, dhul balu sungne ke liye, you won't go. But you are standing there to make your center ki ye diwar tedi hai, ye diwar seedhi karni hai, idhar khidki banni chahiye.
Wow.
So it was a very, finally in 2006,
Gee.
we got the equipment, we got started, and 2007 November, my first IVF pregnancy, twin pregnancy, delivered. But even
Wow.
though, you know,
Within a year, that was fast, madam.
quite fast, because I have a pressure from above, not from below, you know. So that was the requirement actually.
That you have to deliver.
Yeah. So this.
So how many secretaries did you have to go through to convince them that you needed an IVF center at Maansi? 3 secretaries. That means 3
Financial,
terms.
administrative, principal secretary, all to sit with them, and not in a single sitting. Frequently after 5 o'clock, I used to go to Secretariat, Delhi Secretariat, and sitting. When they will give the time appointment, then only I will see them. And months together it went off like this, with the trying to convince them, sir chahiye. So that was.
Wasn't it frustrating, Dr. Sudha, that your department didn't want it and the secretaries were not relenting? Sometimes didn't you think and sit with yourself and think that let me just give it up? It's so frustrating. It's getting me nowhere. How did you overcome all that?
That thought never came, Punita. Never came.
Wow.
I thought I have to start here for those poor patients who comes in a clinic and they have no chance to go to the private sector. They have no money. I have done rickshawalas. I have done for malis, means low socio, and they were giving the blessing. And today I'm here with all those blessings from them.
Yeah, I can imagine. I can imagine it's very easy to give up, you know, but you kept on and on and on at it. So that's the message I want the people to understand, that what looks rosy now, what you've achieved now, had so many years of toiling and hard work and frustrations and exasperation. And I'm sure you must have felt the barbs around you who didn't want you to succeed in your.
I will tell you another thing. When the clinic IVF center started, when it was running well, then people didn't like also. So my administration has put some negative person behind me that she will also do the IVF. Obviously, then the fight. My day, my OT, my patient, the way it goes on. It was so difficult. I said that a junior person, if it comes to me, I will just make her understand and learn properly, which I know. I'm very fascinated about teaching people. But you should learn like this. Still, I have in Matritva, I have 3 ICOG and 3 Indian Fertility Society fellows to whom I make them learn. And by, till date, I have at least 20 fellows after my retirement. I have made it. But
wonderful.
It is very, very difficult if a same rank person comes and poke, but it was administration wanted that I should not be succeeded. That is the reason. But it was difficult time, but I am so happy. Nearly more than 2,000 babies are there now and giving me blessings. Those couples are real so happy. It was very difficult task, but it gives a satisfaction.
So once you had established center in Maansi, how did you go about selecting your team? You had one person by the administration. What about the rest of the team? How did you pick and choose that this person will fit into this role? This will be doing this. Did you have an interview selection?
In a gynae department, I had a very good staff nurse who became sister. Since staff nurse, we used to work together. Johnson. I asked Johnson, will you work with me? Then I will go to matron. And everybody used to think, oh, Johnson, to bas aisi hi hai. Okay, if Dr. Sudha wants to take to IVF, then let her go. She was the cream of the whole nursing staff. When sister in charge sits, she can make everybody right.
Right.
She came to me. I didn't have any embryologist, any technician. Then I got one person who was in the microbiology who used to take the attendance of the students. I got him as a technician. Then I have made him learn that how the IUI or andrology will work.
Okay.
Then, one day, Dr. Akhtar Hussain, he was the head of department of biotech of Jamia University. He came to me. He was a very good friend. He came to me and he said, I got a boy who does not know proper English. So he is not getting PhD to anywhere. He is MPhil and he is net qualified. I said, okay, I will make him and I will start making him to stand in IVF lab, and then he will learn slowly that what exactly, because he has not touched the human thing, he was under the microscope. So finally, after 6 months, he started doing the oocyte hunting, so little bit. Then by the time I became a PhD supervisor of Delhi University.
Wow.
So I said, you will do the PhD if you are interested. But yes, I want to. Finally, he did on follicular fluid interleukins. Which interleukin is the best for the implantation?
Wonderful. Wow.
So my journey is very long and tough, but at the end, I have succeeded to get everything. The only thing I wanted to start in Maansi, the teaching, the fellowship of reproductive medicine, but my administration said that you will give the training to the dispensary people, CGHS people, who are sitting in dispensary.
Yeah.
I said, they are sitting in dispensary, they cannot work for IVF. I want the young girls who are going for IVF for the reproductive medicine.
Yeah.
They should learn properly that how the ethically we should do, because now.
No, but when you were showing results, why didn't you could get the secretaries and the principal secretaries your way of thinking. Why didn't the administration, when they saw results unfolding and you delivering, what was stopping them from adapting the fact that you know more in the aspect of IVF to follow what you were saying?
They said first we should teach the government personnel, even though they are sitting 9 to 2 in a dispensary. Who comes? Relaxed life, absolutely.
Absolutely.
So I ran, but after that, after certain years, the energy is not there that you will keep on doing. I wanted to do research, that embryology lab, one should, on the animals we should start. I had lots of thinking, but but anyway, a good IVF center was stated, and this was the first of its own kind. And we have done lots of, and one thing, yes, government has given all A class. Whatever I used to write, I need this equipment, I have not compromised on anything. So I have taken a best equipment for the Maansi. And only gonadotropin injections patient used to take by their own.
So how did you, Dr. Sudha, how did you manage? This was the technical aspect, that you managed to train an embryologist, you managed to have your nurse with you who could do whatever you wanted her to learn. How did you get the doctors, the junior team of doctors to be able to support you in IVF? You couldn't be the single lone person. So how did you pick up that team? How did you select those people who you thought? You picked up a wonderful staff, Johnson, and which people didn't understand that she's good, she's a cream, and she's going to deliver. You had the eye to spot Johnson, you had the eye to spot this person from Jamia Millia. How did you manage to build up your junior staff, junior doctor staff?
So for junior doctor, I was unit in charge by the time. So my postgraduate were there. So I made a rotation of a postgraduate. One postgraduate will go for 2 months and one senior resident will go for 2 months. One was this rotation. And the younger to me was Renu Tanwar, who is looking after the IVF right now.
Wow. So I know how I know Renu Tanwar. She's from Gangara.
I know her. She's DNB from there. Yes.
She's such a soft girl and wonderful person.
Wonderful.
And so easily moldable to be learning. She reached you. I think that's fantastic.
And she's the coordinator in charge of the IVF right now after me.
I'm so proud of her.
Yes, very good. So she to whom I have really shown her haath pakad ke sikhana jo hota hai. So small minute thing, and everybody finally, one thing more, I wanted to start the FNB.
Okay.
With my that was also my dream, that I should get the proper doctor who are really oriented for the IVF. So I wanted that. Natural, and then I made the file again for the FNB, that these are the requirements. And me and that boy who did PhD under me, Yogesh, we went to Dwarka National Board, and it was 7:30. We were sitting outside on the bench that our turn will come and then we will present our case.
Yes.
When I entered, then he said, Dr. Sudha Prasad, where you were so many years? Every year we used to wait that you will ask FNB.
Oh my God.
It was a very interesting. I want, if you should have given, I was thinking that government sector, will they be entertaining to us or not? But no, every year we used to wait. Finally, I said, shall I present? But no need of presentation. We know.
We're already ready to give it to you in a platter. Take it for your asking.
2 FNB students I got, and after 2 years it became 4. So 4 FNBs are there in Maansi right now.
Fantastic.
It was
fantastic. Gee, another aspect about patient selection. You had such a load on the center. I'm sure the moment you started IVF, there must have been hundreds of patients lining up. How were you picking up that, okay, cost-wise, how much did the medication cost the patient? How did you say, okay, these will be my first 10? How did you keep the rest waiting? Because none of the other medical colleges were having this kind of a facility. How did you decide, okay, these are the most deserving ones? What help could you give them to arrange their funds? How did you go about that? The patients, you had loads of them, but how did you select?
There was lots of load. You said hundreds. We used to get 200 patients, 200 patients in Monday afternoon between 2 to 4.
2 hours.
In 2 hours, 200 patients, and we used to be 4 persons.
My God.
How we used to work on that, you can't imagine. Within. So you have to call them in a gynae OPD, you have to investigate them. And, you know, the person, we wanted the good selection first, in the first few months. That if we are going to do IVF or IUI, because IUI also started at that very time in a good, nice density gradient, sperm washing and all. So we started. So we have made the good selection, less than 35, young patient who understand. They never used to understand, you know, totally low literacy. So they never used to understand. We used to counsel them. We will do like this, then we will make in dishes, baby, and then we'll put, okay, madam, jo aapko acha lagta hai kar dijiye. I need only the baby.
Yeah.
Used to be there.
I can imagine.
In first batch, I did 20 cases. Okay. And we went from our center at 10:30 in the night. After finishing. There was lots of load, and it was a fantastic success rate when it started, because it was absolutely A grade, and I monitored each and everything myself. There was nobody other than me who used to manage culture aaya ki nahi aaya, cleaning hui ki nahi, aapne swab kahan pheka.
You are one army in that case.
Single army. Yeah. So, it was a fantastic time, but it was a craze. You can say, Punita, it was a crazy thing.
Yeah.
कि स्वीप कर रहे हो तो वो कपड़ा कब निकाला था, आज नया निकाला कि पुराना निकाला, कहाँ फेंका, means something like this also I used to see. Okay. So it was a difficult task, but the patient has to, you know, public sector, when the patient comes, they don't want to spend money.
Yeah.
Because they know.
Get those injections, which were so important.
So they think that everything will be coming from the dispensary. Okay. So my first pregnancy came at 17,000 rupees. Only 17.
How did you manage that?
That time only the urinary gonadotropin I have given, and on a very 40% discounted price.
Who paid up for the rest of the 60%?
He said, I will manage, I will do. I can spend 15 to 20,000 rupees. I said, okay, I will try my best in that only. So 17,000 was the cost of first IVF twin pregnancy.
My God, that must be a world record, madam.
It happened like this.
Oh my God.
It was very great. And for a low poor patient, I used to beg the gonadotropin from the different companies. Bhai, 5 aap de do, 5 aap de do, something like this, you know, for 10 days course, I used to beg from the companies.
My
that
God.
Yes. And I must tell you, the companies like Bharat Serum, like Intas, has really helped me. Helped me for this. And I can see the LycoRed. I have done the work with Ashok Kumar and JB Sharma on LycoRed. So we started giving LycoRed also to
all right.
infertile, because lycopene is a very good antioxidant.
Absolutely.
It has really worked very well.
Right. Wonderful, ma'am. It gives me goosebumps to be in your position. And I think what an achievement. What an achievement. Another thing I was wanting to ask you was, what about patient compliance? Because this is a very timed thing. IVF is very timed.
Yeah.
A lot of the patients coming to the have that importance of time. So how much time did you spend on counseling them that आपको इतने बजे से इतने बजे तक आना है, इतना दिन वेट करना है, फिर अल्ट्रासाउंड कराना है, फिर बीटा HCG कराना है, and the works. It is so timed and so precious that if they don't follow it, did you have one person assigned for counseling, or were you doing it all on your own, or everybody at every station?
My junior staff, and finally me. First, they used to give the booster that yes, this is the way we will do these many times. आप आ पाओगे कि नहीं आ पाओगे? You have to come there right in time. And people used to sit outside long row, which is not there right now. I have got the message कि आपके समय में तो कमाल था कि full of my, if you have seen the Maansi, it is close to the parking.
Yes,
So
I've
the
seen.
whole parking, the patient used to sit there that Dr. Sudha will come and we will show her. So this was the story. So the time ki koi problem nahi thi. The time was there. People used to understand that yes, they have to come right in time. They have to take the injection, and many patients didn't have the fridge also to put the gonadotropin.
Exactly.
Every time they used to come to the center to get the injection. And on Sunday, when the IVF center is closed, they used to be admitted for one day for Sunday getting injections.
Wow.
You know, this was the story. So people have worked. My postgraduate has worked. My resident has worked with me, and they used to really do the counseling. And they really were learning also that they really required this much of pain.
Yeah. No, I can see the toil you must have gone through. But what an achievement, ma'am. After all that struggle, when you reach to a point where your patients are giving you the blessings, the results are giving a tight answer to the people who didn't want you there, and your juniors are understanding the kind of work that you've done to get this going, and you are ready to percolate down all your knowledge to your juniors. What more would you ask for from a person who was struggling since 2000, I don't know, 93 onwards? You were at it, and I think you finished with an aplomb, with the center right there, and successful to that. I feel like doffing my hat to you after knowing your journey. It's been a fantastic, inspirational talk, and I'm sure my listeners and people who are viewing us will take home the message that is persistence, perseverance, and sheer hard work that gets you what you want
and
to do.
They should stick to ethical. Ethically, if you stick in reproductive medicine, your flavor will go all over.
Absolutely. That holds true for any aspect. And I feel what you were saying, no, there were rows and rows of patients waiting for you. I think the patients sense the genuineness of the person. You know, whether they are literate, they are not literate, they are moneyed or not moneyed, that instinct is always there. When the patient judges, okay, this is my doctor, and she'll go all out to all lengths to get me what I have come here for. I think I salute you, madam. It's been fantastic talking to you. So
nice of you. You have given the opportunity to make it listen my story, my steps, the way I have really struggled, because people thought that I have become mad and I should throw the file somewhere and just run away, resign and just go.
You bottom line is that you have to have that madness, and you know the zid jise kehte hain, that you have to just go for it and achieve it, come what may. I think that's the bottom line.
So nice.
And thank you so much, madam. It was a pleasure having you and listening to your steps and how you overcame all of that. I hope my beginners and people who are wanting to start a center understand how difficult it was back then when, learning yourself was a problem. You had to go out to learn things. And now everything is ready here in India. There are lots of people who are ready to percolate that knowledge. So it's much easier for them. So they should not be frustrated. They should not be exasperated. They just need to reach out to people like you who are ready to teach anytime and every time.
I will be happy. Still, I'm teaching, and I will be happy to disperse my knowledge.
Thank you so much, ma'am. It was a pleasure.
Thank you, dear.
Yeah. Thank you, Deepika and Jagsonpal, for holding us.
After a
for this
long time,
webinar.
I'm watching Jagsonpal here, Deepika here.
Thank
So
you,
nice
ma'am.
of you, Deepika.
Thank you so much, ma'am. Thank you. It was
They've
really
always been
inspiring,
there.
your story.
Yeah,
They've
you know
always
very
been
well.
there.
You know very well since beginning. Yes.
That's true.
Mm.
Yeah, just a second of, a little video that we have.
Sure, Deepika.